This week we're talking about uh, two chapters in your book. So that'll be 22 and 23. So neurological disorders and then endocrine disorders is what we'll be covering. And you guys will have a lab this week. If you were not able to do the Module 4 exam last week, you will have that this week in your lab. So make sure that you're prepared for that. That you've been studying
What,
and staying on.
what chapters is that on again?
Um, Module 4 started with. Let me see if it was 13 or 14. No, 14. I think is where it started. Yeah, 14 through 19 will be the chapters. And you've got the study materials at the end, the last week of Module 4 in there. And so if you guys, and I feel like none of you took the exam last week. So if you didn't take the exam last week, it'll be up this week. So you guys will have that in your lab, and then you'll have your lab stuff on these chapters. So we'll talk about neurological disorders first, and then we'll discuss some endocrine disorders, and then we'll get you out of here. Any questions before we get going? All right. Well, here we go. Neurological disorders, when we think about these, there's probably a couple that jump right out at you. And then we'll talk about a few that maybe not as prevalent. What would you think would be the most prominent neurological disorders?
CVA, seizure.
Okay. CVA and seizure are probably the top two. And then we have a few others that we'll throw in there along the way. Your book starts off with a little anatomy and physiology, so make sure that you have a good understanding of the parts of the brain, um, what parts of the brain control what functions in the body, and then they take you into uh, a lot of different areas from there. So with neurological disorders, most likely chief complaint we're probably going to see is an altered mental status of some sort. So whether it's a seizure or a CVA or some other type of event going on, in a lot of cases, the patient is going to be presenting with some type of altered mental status. So there's an acronym out there that's in your book. They've got a nice little chart for it on page 573. If you're looking in your book, there's a nice little chart, an acronym for altered mental status on things that you can check that would kind of eliminate what's going on. So the acronym is AEIOU TIPS. That's TIPS. So all of your vowels and then TIPS. And so what they mean is the A is for alcohol, the E is environmental or epilepsy, I is insulin, O is an overdose, U is uremia, which is renal failure, and then tips would be trauma, infection, psychosis or poisoning, and stroke. So that covers quite a bit of all of the things that are going on in these two chapters. So if you check for those things, and as you can check them off or rule them out, either potentially there or not there, or a cause or not a cause, not a factor, that would help you narrow the list as to the cause of the altered mental status. For this mnemonic, AEIOU tips: alcohol, environment, insulin overdose, uremia, trauma, infection, psychosis, stroke. What's the easiest one and quickest one to rule out? Any idea?
Stroke.
Stroke? That would go fairly quickly. And how do we rule that out?
With a stroke screen and field.
Yep. So your book has both Cincinnati and Los Angeles pre-hospital stroke screens in it. Gives you the areas, the things you're checking for, what you're looking for, positive or not, and how to categorize that. And so if just so you guys know, for pre-hospital stroke screens in the field, if the stroke screen is positive, then that's you percentage wise, historically, that's more than 90% accurate that the patient is positive for a stroke. So if you do a field stroke screen and it shows positive for a stroke, most likely they're having a stroke. And then statistically over 90% of the time. What else is easy to run off that list?
Alcohol.
Alcohol. And typically we're going to have to take their word for it. You know, if you see it or smell it, then you can go with it. You can ask them, and then it's, you know, whether or not they want to be truthful. So that's fine. But yeah, you can usually get that off the list pretty quick. One more you can get off the list pretty quick.
Overdose.
Maybe. Depending on the situation, we may know if it's an overdose pretty quick. The one I'm looking at is dealing with the diabetes. So the I is insulin. We may not know about the insulin, but we can certainly do a quick blood sugar on these folks and figure out if it's a sugar related issue. So hopefully you guys are doing blood sugars on all of your altered mental status calls, because in a lot of cases we'll talk about, you'll see that stroke patients and hypoglycemic patients are going to have a lot of similar presentation. So if you are having a patient with altered mental status and you're trying to determine, then yeah, it could be a quick and easy way to do a finger stick and maybe rule the hypoglycemic part out, as opposed to the person having a stroke. So let's focus in on stroke real quick. There are two types of strokes that occur. Anybody know the two types?
Ischemic and hemorrhagic.
Okay. So we have ischemic strokes, which is the clot. That is where they have a blood clot somewhere in the brain. And then we have the hemorrhagic strokes, which is going to be where a vessel has burst and they're bleeding out into the spaces in the brain. So one versus the other, fixability wise, it's probably going to be easier to fix the clots than the bleed. In a lot of cases, the bleeds are going to lead you to surgery. So they're going to have to go to a neurosurgeon where they're going to probably be drilling some holes to relieve pressure, and then they've got to get in there and do some cauterizing to stop those bleeds. If all that can happen in a timely manner without increases in ICP to the point where the brain herniates and they don't make it. So with the ischemic strokes, the clots, we do have some medications not on the ambulance, but they're in the hospital. They have a clot busting medication. Are you guys familiar with this?
TPA.
TPA. So historically, we have been wanting to fly these patients to a stroke center and get them in the air, get them off to the stroke center, and get them there in as quick a time frame as possible, so that they can get this stuff going. But in the last little bit, our protocols have changed a little bit, and our destination choices have changed a bit. So in this area now, most of the hospitals that at the local level are capable of administering and starting this TPA process. So now, if we are dealing with early onset stroke symptoms, we can, rather than having to fly these people off to a stroke center, we can transport by ground straight to the closest facility where they're going to go off to CT to get a scan to kind of figure out which type of stroke they're having. And once they figure out that it's not a hemorrhagic stroke, they're going to start them on the TPA immediately and start trying to break up the clot and restore blood flow to that part of the brain. So it's a change for us. It gets that TPA going a little quicker than maybe flying these people off, and hopefully it'll have a better outcome. They've also increased our window for time. So our window used to be a 3-hour window of last seen normals, and they've increased that time now. So that window is getting wider and wider for us, which is good, because what you see a lot of times is patients don't feel well, and they'll go to bed thinking that they can sleep this off when they're actually having a stroke. And going to bed is the worst thing they can do, because that's going to make the deficits permanent by the time they wake up, and the symptoms are still there and probably progressed and gotten worse. So if they're doing that, that's about the worst decision that they can make. But it also handcuffs us in our abilities to make a difference. So if you guys are seeing that in your stroke calls, I know I've seen quite a few people thought that they could, essentially thought they could sleep it off and in the older populations, and they were actually having a stroke when they went to bed, and it's just sitting there progressing and killing brain material the whole time. So what do stroke patients look like? Whether it's, let's just focus on stroke in general, and then we'll we'll talk about the specifics between the hemorrhagic and the ischemic. But what does a stroke patient look like?
Facial droopage, weakness on one side or the other, slurred speech, pupillary response could be different in each eye. I think that's about it. Motor skills could be off. They could not be able to lift, or
Very lethargic.
coordination could be off.
Yeah, so those are the classic signs: facial drooping, slurred speech, weakness affected on one side, usually grip, fine motor skills, ability to stand or walk, that sort of stuff. And what's frustrating to the stroke patients is that when we ask them a question, we get a very slurred, incomprehensible response, but to them, their response is clear. So they think that they're speaking clearly in their mind, but what we're hearing is completely just garbled. And in a lot of cases, if you're trying to ask them questions, you'll see that frustration come out on them. So in most cases, what Derek just described is probably going to work out to be an ischemic stroke. That would be the blood clot, and that's typically that presentation of what you would see from them. Anybody have an idea of the differences with the hemorrhagic stroke?
Is the hemorrhagic stroke worse than the ischemic stroke?
Worse as far as what?
More deadly
Yeah,
or fatal?
the thing about the hemorrhagic stroke is that if the bleeding doesn't stop or isn't controlled, it's going to eventually increase the intracranial pressure to the point where the brain will herniate and people will die. So with the ischemic stroke, depending on where it is in the brain, maybe the worst that happens is those people have permanent deficits. So, they may have permanent one-sided weakness that never recovers. They may have permanent slurred speech that never comes back to normal. So you could see some permanence with the ischemic stroke, whereas with the hemorrhagic stroke, if you can't control the ICP, it could be fatal. But the signs and symptoms are a little bit different. So what you'll see with the hemorrhagic stroke is typically those people will have a very severe headache and they will have nausea and vomiting. So those are kind of two telltales that steer towards hemorrhagic versus ischemic. There is I will tell you, in the field, there is no clear-cut way to determine which type of stroke they're having. They really need to have the CT scan to do that. So do you guys know what they're looking for on the CT scan?
Say it again, Cliff.
Do you know what they're looking for on the CT scan when we take the stroke patient?
They're looking to see where the bleed is or the clot is.
Okay, so
to confirm.
That's not that's not accurate 100%. When they do a CT scan for these stroke patients, the scan only shows one thing, and that is if there is a bleed. The scan does not show any clots or blockages. So what they're doing is they're doing the scan, and if they don't see any signs of a bleed, then they're assuming that it's a clot.
Even when they use contrast?
Well, they don't, in the emergency setting, they don't use the contrast. So that I'm aware of.
I saw them do it the other day.
Did they?
Yeah, I went with them when they did the CT scan, and they did it regular, and then they did one with contrast.
Right away?
Yeah, like we went straight up there.
Okay.
Yeah, because they established IV up high to put in the contrast.
Right. Okay. Well, if they're doing that, then they're looking for both. But typically in the CT world, the what they're looking for is that area of, and the bleed will show up as a very dark area on the films. So they're looking for the bleed. And if they get the bleed, then obviously they won't do the TPA. They're going to send them off to the stroke centers for the neurosurgeons to do surgery. But if they don't see any signs of the bleed, then they'll go start the TPA right away. The other thing we should talk about is a TIA. What's a TIA?
A mini stroke.
Yeah, people refer to it as a mini stroke. I think a better word is a temporary stroke because of what it does and how it changes. So what does a TIA do? What's happening when that occurs?
Is that when the brain loses blood flow and oxygen for a certain amount of time and then regains it?
Right. So these patients will look like stroke patients. They will have a positive stroke screen, and they will, have those signs and symptoms. But with a TIA, the issue will resolve itself. It will fix on its own, usually in a short amount of time. Whereas with the ischemic stroke, that clot is usually there and stuck there. But with the TIA, over the period of anywhere from a few minutes to a few hours, all of the symptoms will go away and everything will be resolved. The patient will come back to their normal functions on their own without medication.
Well, me and Celia picked up a guy from Lowe's about a month ago. He presented with stroke-like symptoms, and then he would be fine, and then he'd present, and then he'd be fine. And actually, come to find out, what he had was actually called a rolling clot. So it actually, when it rolled, it would block everything off, and he would present like a stroke. And then when it rolled back the opposite way, I'm guessing that's how it is. Then he would clear up and be his normal self, and he knew what was going on.
So he has a clot that's in there, and it's kind of shifting around. And when it shifts one way, it blocks blood flow, and when it shifts the other way, it allows for blood flow, which allows him to present like a stroke patient and then to not. That's pretty weird. It's a good thing that he knew what was going on, though. All right. So with the TIAs, though, usually a few minutes to a few hours, and in most cases, in less than 24 hours, they will be resolved back to themselves. They do refer to these, as Derek said, as mini strokes. A lot of people will refer to those as mini strokes. So if you're hearing people say they have a history of mini strokes, that means they have a history of TIAs. What I have seen in my experience is that TIAs is leading to a serious stroke. Most people that I know that have had a series of TIAs have eventually had a massive stroke. So if you're frequently running on people with these TIA-like symptoms, get ready because the big one's on the way.
Is there anything they can do to help prevent that?
Well, they really don't. From what I've seen, they really don't have a good understanding of what's going on, and they don't know how to prevent it. You can treat the at-risk factors like hypertension. You can't really do a lot about family history or genetics, but all of the things that you can see the list on 576 in your book, they have a list of stroke risk factors. And a lot of those you may not be able to do anything about, but some you can. You can't do anything about your age. You can't do anything about your family history, or your gender or ethnicity and those types of things. But you can when it comes to, smoking and obesity and drug use and alcohol and those types of things. Your lifestyle, you can change that. But I think that you'll see with a lot of neurological disorders, strokes being one of them, seizures being another, and then just syncope as a whole under a big umbrella. They just really don't know what's going on or how to anticipate what's going to happen. So let's talk about stroke treatments at the A level. What are we looking at as far as stroke treatments? We've done the assessment as an altered mental status umbrella. We do the screen out in the field. We get a positive stroke screen, so we're going to say they're having a stroke. What do we do as far as treatments? How are we going to handle these folks?
Well,
Oxygen and fluids.
I don't know.
IV, blood draw, bring them to the right facility, and just get. I mean, there's not much any level can do for strokes.
Okay, so I heard oxygen, fluids, IV, and blood draw. Is that what I heard?
Yeah, because I mean, there's not much that you can do at any level.
Right. Okay. So in the field, we don't have the fibrinolytics that we need to bust up the clot. So on our ambulances, we're not carrying the TPA. We're also not carrying CT machines. So, diagnosing it is one thing and treating it is something else. What's important about the treatment and how we decide what facility to go to?
Time is important.
Yes, that is probably the biggest thing. Once you determine field positive for a stroke, the next thing is going to be time. And when we're talking time, we're talking how long has it been since the last time somebody knew they were normal? And so we want to kind of get that time frame down. Has it been minutes? Has it been hours? Has it been days? And see where we are. I said our window for time is getting wider. Anybody know how wide that window is now? It used to be
12
3
hours
hours. How many?
Isn't it 12?
12? Not that wide.
And if,
Six.
is it 4 or 5?
Mm-hmm.
It's 6 for EMD.
So
I don't know what y'all's is.
she says EMD has a
Crystal.
6-hour window. I think EMS, the window has gone from 3 to 4 initially. And then for neurosurgeons themselves, they're extending this window out even as far as 18 to 24 hours in some cases. So they will still try the TPA and different things for the clots and try to bust those up and see if they can restore things and get some function back, and even in those longer hours. So I think for EMS, local protocols right now, I think a 4-hour window is what it says. So if they're less than 4 hours, we're going to transport straight to the close, because in this area, all the hospitals have it. So we're going to transport to the close hospital, get the CT done. We'll call them and let them know, call the stroke alerts, let them know. And then when we get there, get the CT done, and they can find out which way they're going to go, whether they're going to go TPA or if they're going to go transport to the neurosurgeons. All right. So not a lot going on in the treatment world for the stroke patients. What about seizure patients?
There's not much we're going to do at the A level either, because we can't give the medication that they need.
Okay. So do you guys know the medication that Derek's referring to?
Versed.
Versed is one. Anybody know another one? No. So Versed is a benzodiazepine. The other one is Valium. Versed or Valium are probably the two most used by EMS. Valium, as of late, has become a little difficult to get, so Versed has become like the number one choice. And Versed is a kind of like think of it as like the Narcan for seizures, because you can give it in a bunch of different ways, intranasally being one of those ways. So just like we do Narcan for the overdoses, put the atomizer on, squirt it in their nose. You can do the same with Versed with these active seizure patients. So that'll help slow them down, calm them down, and stop the seizing process. What causes seizures?
A neurological problem.
Yeah, no kidding. Yeah, that's the easy way out. So for people that have seizures, they can be triggered by a lot of different things. In the younger kids, usually the most triggers that they will have is either spikes in their fevers or overstimulation by like flashing lights and that sort of thing. A lot of that sensory stimulation would actually send them into a seizure. So those are the two typical reasons I know of for younger people. Adults, older people and adults, they older kids and adults, most people that have seizures have a history of having seizures. So at some point they started having seizures, and then once it started, it has kept on along the way. And hopefully these people control these with medication. There's a lot of anti-seizure medications on the market that you'll see these people are taking. Dilantin being one, probably maybe the most common you'll see is Dilantin. if they tell you that they're on that, then you can expect that they have some history of seizures. In the adult population, if you get somebody, 20s, 30s, 40s, 50s that has never had a seizure in their life and they have a seizure, the number one reason for that statistically is the development of a brain tumor. So if it's a first-time seizure in an adult person, be highly suspicious that they have a brain tumor. And they'll find that on the scans when they get them to the hospital, if that's the case. It's not something that we're going to diagnose in the field or do anything about, but for their long-term care, that's going to be a reality that they'll be dealing with. So number one cause of seizures in people with a history of seizures? Anybody?
Non-compliant with meds.
Yep, that's it. So if they have a history of seizures, then typically the reason they're having seizures is they're not taking their meds or not taking them regularly or not taking them correctly. And in most cases, we'll hear that the reason why they're not taking them is they don't have them or can't afford them or something like that. Treatment-wise, what are we going to do? Derek said we're not going to do a lot, but what are we going to do?
IV, blood draw, fluids possibly, depending.
Okay.
Keep them safe while they're seasoned from hurting themselves. Because you can't stop it. You just got to keep them safe.
Okay.
Oxygen.
Maintain the airway. However you determine to do that, manage the airway on these folks and maintain that. So protect the patient, keep them from doing further harm to themselves. Don't try to hold them down physically, because it'll only hurt them. And then the rest will be supportive care. So oxygen, IVs, if they need fluids, those types of things. So there's a lot of environmental triggers for seizures. Drug use, drug overdoses, sensory stimulation. These kids that are playing video games all the time and they're in front of these video games for hours and hours and hours nonstop, that is a sensory stimulation and can lead to sensory overload, which will trigger seizures in them. So be wary of that. I don't know. It's one of those things that's not really well understood, but if they're actively seasoned, you should also consider getting some medic assistance there. In a lot of cases, the seizure, by the time we get to them, the seizure's already stopped, right? So if these people are if they actively start seizing, in a lot of cases, less than 5 minutes, it's done. And by the time we get there, they're in the post-seizure state. What does a post-seizure state look like?
They're just out of,
Dazed. They look dazed.
Okay. Dazed. In a lot of cases, they're going to be tired or sleepy.
Confused.
Most of the time, they urinate on themselves. Different things. Seizure is very hard on the body. It's very taxing. It takes up a lot of energy. So checking blood sugars on these people in the post state is probably not a bad idea, because it burns. When a patient has a seizure, it burns a lot of calories, uses a lot of energy. It tires them out. They really feel like they've done a lot of work, and their body has done a lot of work. Your book talks about vertigo. What's vertigo?
When you feel dizzy, like standing up, can't keep your balance.
Okay, so it's an equilibrium issue, and patients, that's their, most of the time, their chief complaint is dizziness, and usually they'll say, "Can you please make the room stop spinning?" And what's the cause for it?
And it's something with their inner ear.
Yeah, it's actually an infection in the inner ear. It's a viral infection, and it causes that dizziness and that equilibrium throw off. What's our treatment for that?
Get them to the hospital.
Yeah, it's all going to be supportive care, because we just don't have, at the A level, we just don't have a good sense of medications that we can give, or treatments for that. They do have some over-the-counter medications that those people can take, and it'll help with that.
Meclizine.
Meclizine is the generic. Dramamine is the brand name, and so they can take that and see if that helps over a few days. But typically, the doctors are going to prescribe that medication to them, or suggest that they get that medication. So it'll work out, hopefully, for them. And your book talks, for the rest of the neurological disorders, your book goes into a lot of little things like Bell's palsy and Parkinson's disease. It talks about dementia, different things like that. So there's a lot of little categories where there's a bunch of different things that you can look at there. But I think the biggest takeaway from this, the big categories with neurological stuff, is you're gonna fall into the big umbrella of signs and symptoms being altered mental status, and then the bigger categories of problems will be strokes, seizures, syncope, are probably the top three, and it'll go down from there through the rest of those categories. The other big takeaway from this chapter is anatomy and physiology. So make sure that you have a good understanding of that. And that'll get you through there. The other chapter 23, is endocrine emergencies. So disorders with the endocrine system. What does the endocrine system do?
Hormones.
Hormones. Regulates hormones. Sure. What else?
I mean, in your pancreas and like insulin and that part of the endocrine system also.
Yep. Yep. So the
Adrenal
pancreas is
glands.
one of the things which regulates insulin, dealing with your blood sugar levels.
Adrenal glands,
Yep. Adrenal glands.
the ovaries.
Ovaries, the ovaries and testicles, that's where the hormones are. Let's go up a little higher. What's up higher?
Your thyroid.
Thyroid.
And the thymus.
What does the thyroid do?
Regulate weight gain.
What else?
Or doesn't it help regulate your hormones also?
It does. Weight gain,
If you have, like, the
because
thyroid storm and
thyroid controls metabolism, which is where the weight gain or loss comes in. It does control some hormone development. The big thing about the thyroid is it also controls heart rate. So it has the ability to, and that's how it does the metabolism, by controlling heart rate. So if you have an underactive thyroid, it can actually slow the heart rate down into a very bradycardic state, which is why people gain weight. The hormone issue, along with the slowing heart rate, slowing metabolism, causes people to gain weight. And on the opposite end, if you have an overactive thyroid, higher heart rates, faster metabolism, weight loss, those types of things. Another thing from the thyroid is hair loss, because it throws the hormones off. So it'll cause hair loss. So which gender does the thyroid issues affect more, men or women?
women.
Women, yes. So hair loss in women, directly connected to thyroid issues. Crystal brought up thyroid storm. That is a medical emergency that happens in an overactive thyroid. So what'll happen in a thyroid storm is basically like a runaway thyroid. It'll just go crazy on the hyperactive end. So what you'll see is an increase, and you'll see this as a dramatic or severe increase in heart rate, increase in blood pressure, and most importantly, increase in body temperature. So they get really hot, heart beating really fast, blood pressure shooting up, and that is what causes that storm effect. So these people need some serious attention to cool them down, slow them down, and get that blood pressure down. So from the endocrine system, biggest, most popular problem that the endocrine system causes for us in the EMS is what?
Diabetes.
Diabetic problems.
Yeah, diabetic problems. Probably first and foremost. We'll see more of these than anything else. So whether it be on the lower, the high end, hypoglycemia or hyperglycemia, we'll be dealing with diabetic issues more than probably anything else. So treatments are very different for hypo versus hyperglycemia. Do we really need to know whether the patient has type 1 or type 2 diabetes?
Not really, unless you're looking for an insulin pump, I would guess.
Okay. It's
Depending on the situation.
What's that?
It depends on the situation. If you have a peds or a young child with symptoms, you would know it's a type 1.
Right. Yeah, you can figure it out probably. Is it important to us? Maybe, maybe not. Probably not. It's not going to change how we deal with them in our setting. It will change probably the long-term care of what their doctor does with them. But in our cases, it's not going to be all that detrimental if you don't know the difference between type 1 and type 2 unless it's a test question. The actual application in the field is going to be, are we treating low blood sugars or are we treating high blood sugars, right? So,
Right.
so for defining purposes, what is a low blood sugar?
60 and below.
60 and below. Anybody have another number?
And if it's below 60, you've got to treat, right?
Hmm?
I agree. I mean, if it's below 60, you've got to treat.
So it's going to depend on local protocols in a lot of cases. Some people use the 70 number. Some people use the 60 number. What is the key that must go with the number? There's something that must go with the number. The number itself, if they,
mental status.
yeah, they have to have some kind of symptom. They need to be symptomatic in some case. So just because their blood sugar is like 59 doesn't mean we're going to start shooting sugar into them, but they have to have some symptoms to go along with that low number. And in most cases, what does low blood sugar symptoms look like?
Lethargic, sweating, altered mental status.
Okay. Slurred speech, maybe? Combative, agitated, unresponsive in worst cases.
Depending on how low.
Yeah. So while they're still awake, lethargic, anxious, agitated, maybe combative or angry, diaphoretic, those types of things, the mental status will change and eventually they will go unresponsive. So that's what low blood sugar issues look like. So in the early stages of low blood sugar issues, could be a lot
Shaky.
similar. Yeah, it could be very similar to stroke-like symptoms. So be sure that you're not confusing those in your assessment. How do we
Hey,
treat?
Cliff,
Yes.
sometimes it can look like when they're beginning to go into septic shock, you can get similar symptoms. Cause we had one the other night in clinical that was beginning with septic shock, and they were thinking it was her blood sugar
Mm-hmm.
until the hospitalist came in, and then when he came in, he ruled it as septic
Right.
shock.
So hopefully there's a body temperature issue there that you should be looking at, and also try to look at the history, because if they don't give you a diabetic history, then a blood sugar issue would be unlikely. But our quickest way is doing finger sticks and trying to get a number to go with some of these things. So, typically if it's in that 70 to 120 range, or even up to 140, if they're having these issues, and you get a sugar number like that, it's probably not going to be a sugar issue. It'll be something else. But if it is sugar problems, how do we fix low blood sugars?
If they're responsive, we can do oral glucose.
Okay. What if they're not?
And if they're not, we can do glucagon.
How do we do that?
IM.
What's the dose? Knew you weren't going to get away that easy.
Oh, I know. 12.5 or 25.
No,
No. That's oral glucose.
no,
No?
50-50.
that's D50.
Oh, thank you, Keely.
It was Crystal. And then
Oh, thank you, Crystal.
like 1 milligram.
1 milligram for
kilogram or something
glucagon.
Oh,
Yeah, 1 milligram for glucagon. That's an IM
Glucagon.
injection. And then
man.
if we're doing D50, that's going to be an IV. So 12.5 to 25 grams. Then if we're doing oral glucose, that'll be PO, and that's usually 1 tube is 15 grams. So typically 1 to 2 tubes is what they'll get.
Wow.
All right. So
I was way off.
so we can do low blood sugar. We can fix that orally. We can fix it IV, and we can fix it IM. So there's no reason to ever take somebody into the hospital with low blood sugar. Right? Don't go in there saying I couldn't get an IV, so I couldn't give them any sugar. Because that's terrible. Don't do it. All right? All right. What about on the high end? What does that look like?
Same as the low.
Signs and symptoms on the high end?
Depends
They
on
have a
how high it is.
headache.
Sometimes they have that fruity smell in the breath if they're in DKA.
Yeah, if they get to the point of DKA, they'll have that fruity smell. Long before DKA, they're going to have a high sugar number. What's a high sugar number?
When it says high on the monitor.
Greater than 500.
Yeah, if it says high on the monitor, it's a high number. Typically, that's higher than 500 or 600. And you'll have to do a blood test to get an actual number. High, though, is a lot lower than that. So once you get in the 200 to 300 range, that's where it needs to be taking some intervention. So what is our treatment on the high end for these folks?
IV fluids.
IV fluids.
Yeah.
That's all we have on the truck is IV fluids. None of us are carrying insulin or any sugar reducing medications. So all we can do is start some fluids and get that going. And we're probably not going to give them a ton of fluids and overload them in any way, but we're going to start getting some fluids going, because what is a likely sign or symptom from high blood sugar?
Thirst
Because of
and frequent urination.
which causes?
Electrolyte imbalance. Dehydration.
Dehydration. Yes.
Or frequent urination.
Yes. So that high sugar level, they're going to be going to the bathroom a lot, trying to get rid of those ketones. And in a lot of cases, that frequent urination will come with dehydration. So giving fluids is a good thing. We're probably, just by giving IV fluids, we're probably not going to change their sugar level that much. But they'll have to get to the hospitals, start some insulin and other things, and and then the numbers actually start coming down. What's the dangers of having prolonged high sugar levels?
Your kidneys, it'll blow your kidneys.
Yes, you will kill your kidneys. That would be the first thing you kill. You'll put yourself in renal failure for prolonged, uncontrolled high sugar. You will have that. And if you like your extremities, you better not ever hurt them, because that's those people that have the wounds that won't heal. And then they start amputating parts, little parts at a time.
Whew.
All right, so diabetic issues being the big one. It talks about, we talked about DKA a little bit. DKA is the prolonged end of high sugars. And that's where the body has those ketones that it can't get rid of. So fruity smell on their breath. You'll see Kussmaul's breathing, where they're trying to get rid. They're in an acidotic state. They're trying to get rid of some of that ketone issue, and they're trying to blow it off with their breathing, which is a problem. The big issue with these folks is not shifting sugar levels in a fast manner, but we don't really have that issue because we can't shift sugar levels fast anyway on the high end. And then the rest of the chapter just talks about thyroid issues on both ends, the low end and the high end. So hypo and hyperthyroid issues. You get a couple of different diseases or disorders that are named after people. So Graves' disease, Addison's disease, Cushing syndrome, a lot of different things going on there with your thyroid. So make sure that you guys are familiar, especially with the hyper and hypothyroid issues. Seeing a lot more of that in patients these days. Anybody know what those patients are taking? What kind of medications they're taking?
For what? Thyroid issues?
Yeah, especially.
Levothyroxine?
Yeah.
Levothyroxine?
Yep, that's one of them. They're taking some thyroid medications. That's one. Armour is another, which is actually a natural hormone from pigs. And hey, it helps. All right, so, and that gets you right to the end of the chapter. So they've got some really nice charts in this chapter. So make sure you go through those as you're going, contrasting hypo and hyperthyroid, and then all of the help with the diabetic stuff. Really good. Type 1, type 2 differentiations, and that sort of thing. Anybody have any questions?
I like the 7 o'clock time.